Analysing the results of CSF examination. This video aims to provide you with a basic understanding of the information that can be obtained from a lumbar puncture CSF sample. Opening pressure. This important test is often neglected and may result in missing diagnostic information in cases of CSF pressure-related disorders. The normal pressure in the lateral decipita's position is less than 15 centimetres of CSF, with readings of greater than 20 centimetres clearly pathological. BMI is poorly correlated with CSF pressure, however appropriate patient position and technique is essential. Colour. CSF should appear clear and colourless. As few as 200 leukocytes or 400 erythrocytes per ml will result in a degree of turbidity. CSF will appear bloody if containing more than 6,000 erythrocytes per ml. Differentiating a traumatic tap from a CSF consistent with a subarachnoid hemorrhage requires the presence of hemoglobin degradation products, or xanthochromia. These will appear in the CSF after 2 hours post-bleed, so confusion may arise if lumbar puncture is performed too early. Consequently, the timing of lumbar puncture in suspected subarachnoid hemorrhage is important. Xanthochromia also occurs with raised serum bilirubin, associated with that above 15 mg per deciliter, and a high serum protein of greater than 150 mg per deciliter. This table shows how CSF can be analysed for the following parameters. Protein. High levels of protein are the result of endothelial leak into the CSF and reduced clearance by the arachnoid villi. Causes of a raised protein include bacterial infection, inflammation, subarachnoid hemorrhage, Guillain-Barré, multiple sclerosis, and an obstructed flow state. Glucose. CSF glucose is reduced in bacterial, fungal, and some viral infections such as herpes simplex and herpes zoster infections. It is also reduced in malignant and autoimmune meningitis, but to a lesser extent. Gram stain. In untreated patients with bacterial meningitis, the sensitivity of gram stain is 60 to 80%, reducing to 50% for treated patients. Other stains include India ink staining. This is required for identification of yeasts such as Cryptococcus and Candida species. For the differential, classically lymphocytosis indicates either viral, late bacterial, or tuberculous meningitis. Eosinophilia is more common in parasitic infections, lymphoma, or reactive meningitis due to foreign material. PCR has superseded tissue culture for viral infections and is widely available for the following viruses: HSV, VZV, CMV, EBV, JC virus, Murray Valley encephalitis, HIV, and HTLV1. Specific proteins can also be looked for in the CSF. Oligoclonal IgG bands in the CSF, but not serum, indicate an inflammatory response in the CNS. Although these have become synonymous with multiple sclerosis, they are actually non-specific. Cryptococcal antigen testing can also be performed, and this is up to 95% sensitive. Protein 1433 is suggestive of CJD, but again is non-specific.